Hello, my name's Sophie Hasty and I'm the Parent Education Midwife at Swift, which is also known as Warwick Hospital. Welcome to the Path to Parenthood virtual presentation. This is preparation for labour and birth. I hope you enjoy it. The situation, guidance and information around COVID-19 is changing all the time. Please check out the Maternity Updates Swift page on Facebook for the latest information and guidance and policies from Swift. This presentation will cover the labour journey, ways of coping, the first hour with your baby, pain relief and medical interventions, and relaxation. Part 1. Uncomplicated labour and birth. That is the physiological, natural process of how labour works. The last few weeks of pregnancy can be a challenging time. It is common to feel tired a lot of the time, so make sure you rest when you need to. This is easy if you have stopped working, but if you are continuing to work, you may want to reduce your hours or talk to your manager about adapting the way that you work. At 37 weeks, your pregnancy is considered full term, and the average baby weighs around 3 to 4 kilos. Your baby is ready to be born. When you're around 37 weeks, your baby moves down ready to be born, ideally with their head down. You may feel more comfortable when this happens and feel that you have more room to breathe, but you may have more pressure in your lower abdomen and you may feel that you need to go to the toilet a lot. Many women will experience Braxton Hicks contractions during their pregnancy. A Braxton Hicks contraction could be described as a practice contraction, and it is when your uterus goes tight and hard and like a drum and then relaxes again. These contractions are completely normal and can be felt usually from about 30 weeks of your pregnancy, though it could be earlier. They don't normally have a pattern, and they're usually irregular. Sometimes your baby's movements will stimulate them, and sometimes they just come out of the blue. They're nothing to worry about, but if you do have any concerns about Braxton Hicks contractions, have a chat with your midwife. The ideal position for your baby to be in towards the end of pregnancy is with their back towards your left and towards the front and their chin tucked right in. Ways that you can encourage your baby to get into this position are to try sitting on an upright chair, leaning forward, maybe on a dining chair with your elbows leaning on a table. Or you could try sitting backwards on a chair, resting your arms on the back of the chair. Also kneeling on the floor, leaning over a beanbag or birthing ball, or spending some time on all fours regularly, and this really encourages your baby to get into that position. Try to avoid positions which encourage your baby to swing round towards your back. This can include slouching back on a sofa or an armchair, sitting in a car seat for too long. If you need to rest, try lying on your side rather than slouching backwards, and if you spend a lot of time in the car, compensate for that by spending quite a lot of time on all fours as well. Sitting on a birthing ball is a really good way of encouraging your baby into a good position because it makes you sit really upright with your bump forward. Using exercise videos are very useful for helping your baby get into a good position. Have a look online for exercise sessions on pregnancy yoga or Pilates. This diagram shows a baby in a uterus. The uterus is also known as a womb. So you can see some of the anatomy here. You can see the vagina is labelled and also the cervix. The amniotic fluid, which is the water around your baby, and the amniotic sac, that's also called the membranes around your baby. You can see your baby's umbilical cord and the placenta at the top on the right. So the cervix, which is just below the baby's head, is the opening to your womb, and that's what needs to open up to let your baby out. This series of diagrams demonstrates the opening and thinning out of the cervix. That is also known as effacement for thinning and dilation for opening. On the first picture, you can see that the cervix is thick and long and not open at all. That is how your cervix is when you're not in labour. As you go through the latent phase of labour, then your cervix begins to thin out and slowly open up, as you can see in the second picture. In the third picture, it is fully thinned out or fully effaced and is 3 centimetres dilated, so a little bit open. And in the last picture, the cervix is 10 centimetres dilated. We also call this fully dilated. Basically, that means that the cervix has been absorbed into the walls of the uterus and you are ready to push your baby out. Labour can be defined as having several stages. The latent phase of labour is the very early labour during which your body gets ready to go into labour. It can last several days or maybe even longer. Sometimes people don't know they're in the latent phase of labour because it's so mild. The first stage of labour is the more active stage of labour, the contracting phase and dilating phase in which your cervix opens up. The second stage of labour is the pushing stage, so it's the period from when your cervix is completely open to the birth of your baby. The third stage of labour is from the birth of the baby until the birth of the placenta. We'll look at these stages in a little more detail now. Some women pass what we call a mucus plug or a show towards the end of pregnancy. This happens because the opening to the womb or the cervix is beginning to open up to get you ready to go into labour, and the mucus that normally sits there falls away. This is completely normal and nothing to worry about, so long as you're over 37 weeks pregnant. The mucus normally looks like egg white and is often clear, although it can have streaks of blood in it, and this is completely normal. Passing a show may mean that you're going to go into labour soon, but it may still be a few weeks, so don't get too excited. The latent phase of labour is the early stage of labour when your cervix begins to thin out and open up. It can take a variable length of time. Some women won't be aware that anything is going on. Other women will get a lot of contractions. They will get backache and period type pain and find it very uncomfortable. Making sure that your baby is in a good position, as I've already discussed, will really help make sure that your latent phase isn't too long. So do those exercises I suggested. Many women find using a TENS machine in the latent phase of labour very helpful. A TENS machine is a small device which sends electrical impulses into your skin. It has electrodes which are taped onto your back and connected by wires to a small battery-powered machine. Holding this, you can give yourself small, safe amounts of current through the electrodes. There's a booster button, so when you have a contraction, you can press this and you get a little bit more stimulation. It is believed to work by stimulating the body to produce more of its own natural painkillers, which are called endorphins. It also reduces the number of pain signals sent to the brain by the spinal cord. A TENS machine is most effective in very early labour, so it is worth having one at home that you have hired in preparation for your labour. You can find them online to hire, or you can get them from chemists or pharmacies. It is fine to take paracetamol in the latent phase of labour when you're at home. You can take 4 doses, that's 2 tablets, in a 24-hour period, at least 4 hours apart. Don't take more than 4 doses in 24 hours. And when you come into hospital or the midwife comes to your home, tell her what you've taken. Many women find having a warm bath in the latent phase of labour very soothing. Obviously you need to take your TENS machine off before you get in the bath. And be careful not to have it too hot, no more than 37 degrees, which is blood temperature. With within reason, try and stay active during your latent phase of labour. Try and go for a walk, potter around the house, do what feels right to you. You need to take rest as well, you can't be active all the time, but if you need to lie down, try lying on your left side, not your back. Other positions that are good are on all fours, rocking. Sometimes having a massage from your partner is helpful. Just keep moving around, changing what you're doing, and do what feels right. The question I most commonly get asked in antenatal classes is when to call the hospital, when to call the midwife. And I think it's the thing that most people get most concerned about. How do you know when you're in labour and it's time to go to hospital, or time to call the midwife to come to you if you're planning a home birth? In short, when your contractions are strong and regular every 4 to 5 minutes and they last at least 50 seconds. And when I say strong, I mean really strong. They take your breath away. When you've got a contraction, you can't do anything else. You can't have a conversation, you can't walk, you have to stop and lean on something and focus on your breathing to get through the contraction. When your waters break, now your waters can break at any time. It doesn't mean that you're in labour. They can break before labour or during labour, and very occasionally babies are born inside the bag of waters. If you're ever concerned about your baby's movements, ring the hospital. So your baby should move regularly right up until the time you go into labour. You may hear people say that your baby will slow down at the end of pregnancy. This is not true. If your baby slows down or you have any concerns about your baby's movements, please ring the hospital. Anytime, 24 hours a day, the midwives want to hear from you if your baby's movements have reduced. And also, ring us if you're worried about anything, any continuous pain, any bleeding, anything that's unusual or you think is wrong. Give us a call and we're happy to talk it through, and we may ask you to come and see us, especially if we think you're in labour. When you arrive at the hospital or the midwife arrives at your home, the first thing that will happen is that you will have a conversation with the midwife. She will want to hear what your hopes are for your labour and birth. She will also check your notes to see if anything has been recommended for how your labour is managed. Maybe you have been seeing a doctor throughout your pregnancy who has made certain recommendations. You can discuss together how your labour is managed and what your hopes are and what your fears are. So if you have any concerns or any anxieties, please talk to the midwife about them and tell her what they are. The midwife will want to do a full antenatal check, just like she would if you were seeing her at the clinic. She will want to check a sample of urine, so please either go with a full bladder or take a sample with you. She will check your blood pressure. She will also listen to your baby's heartbeat and feel your tummy to check your baby's position. If everything is straightforward and you are low risk, then she will use a handheld Doppler just like she would at clinic to listen to your baby's heartbeat. If there are any concerns about your pregnancy, she may ask you to go on a monitor to check your baby's heartbeat for a period of time. This monitor is called a cardiotocograph or a CTG, and it monitors the baby's heartbeat over a period of time in relationship with your uterus's contractions, and she gets a paper printout of the heartbeat and the contractions together, and that shows her how your baby is affected, if at all, by your contractions. To check that your cervix is opening up, that is dilating, the midwife may want to do an internal examination, that's a vaginal examination, to check that your cervix is opening. To do this, she will ask you to lie on the bed, propped up with a backrest or with pillows, and she will put on a pair of gloves and put 2 fingers inside your vagina to feel for your cervix. And doing this, she will check how open it is. This is a bit like having a smear test, but without the speculum that is used, which is the instrument used to do a smear test. This might sound very scary, but lots of women actually want to know if their cervix is opening up, as it reassures them that their labour is progressing. Once she has completed her checks, you will have a conversation with the midwife about what happens next and agree a plan for how your labour is managed. Oxytocin is a hormone and it has a very important role in labour because it makes the uterus contract. It has other roles as well. When you are attracted to somebody and you feel like you want to make love with them, the hormone that's flowing through you is oxytocin. When you cuddle your newborn baby and you get a great rush of love, that's oxytocin too. So oxytocin is the hormone that helps your baby get into your body, and it's the same one that will help your baby get out of your body. So try and make the room that you give birth in as similar an environment to the one where you might have got your baby in there. Make sure that the lighting is low, you feel safe and calm. Keep it quiet and relaxed. If your labour slows down, try nipple stimulation because that can give you a great boost of oxytocin. Ask your partner to give you a cuddle, hold your hand, talk to you gently. Stroking your skin. All these things will give you a boost of oxytocin. When your baby is born and you have skin-to-skin contact with your baby, you will have a great boost of oxytocin then too, and so will your baby. And that oxytocin will bathe your baby's brain and help your baby's brain develop. It's an amazing hormone, oxytocin. Massage in labour is very helpful. Flat of the hand over the small of your back and the base of your spine, strong, deep, circular motions over that area is very soothing if you get a lot of backache in labour. You need to be upright for this and leaning forward, so standing and leaning on a wall or the back of the bed, or all fours allows your partner to get at your back. If you're not sure how to do massage or your partner isn't sure, just ask the midwife to show you and then your partner can take over. Light touch massage is also helpful, and that is when your partner runs their fingertips gently over your skin. It's quite tingly. Some people find it a bit irritating, but for other people it feels really nice and it helps oxytocin production. At the end of this presentation, there's a relaxation recording which shows you how to relax and how to use breathing as a tool to help you relax. This is available separately and you can use it whenever you want to. So it's on YouTube and it's linked on the maternity portal or on the maternity Facebook pages. It's very useful in labour as well, the recording, but if you do the recording regularly, you'll learn how to do it without the recording, and that's even better because you can use it whenever you like and you don't need any technology available. Breathing in labour there's no mystery to breathing in labour. Just try and use your breath as a tool to help you calm down. So if you feel as though you're panicking, just think about your breathing. Just think about breathing in and breathing out, and breathing in and breathing out. And that alone will really help you calm down and come back to your body if you're panicking or feeling anxious. Staying active in labour is really helpful. Keep moving, try different postures, stay upright and mobile. Leaning forward is really good. All fours is another good position. Changing your position a lot is really helpful. So there's no one right position, just keep changing. Many women like to use a birth pool during labour. Maybe for the whole labour, or maybe just for the contracting phase or for the pushing phase. These pictures show two different types of birthing pool. The one on the left is an inflatable pool suitable for a home birth, and the one on the right is one of the plumbed-in pools at the Bluebell Birth Centre. If you're planning a home birth and you'd like to use a pool, we have several at the birth centre that we can hire out to you. Speak to your midwife for more information. It's very important that you're low risk if you use a birthing pool, because we can't monitor your baby quite so closely. So you need to have had a straightforward pregnancy, and it needs to be anticipated that you will have a straightforward, uncomplicated labour and birth. The water shouldn't be too hot, so it should be blood temperature, which is 37 degrees or a little cooler. If it's too hot, it can put your heart rate up and that can upset your baby. The midwife will still listen to your baby every 15 minutes in the pool. The benefits of using a birthing pool are that the water takes the weight out of your body and it eases some of the discomfort of your contractions. It doesn't take the pain away, but it's easier to move around and it's very soothing and very relaxing. If you like a long bath, you'll probably love a birthing pool. If you don't like water, it might not be for you. But whichever way, if you fancy it, give it a try and see how it goes. If you don't like it, you can always get out. Entonox, or gas and air, is the most commonly used drug in labour. It's a gas that's breathed in through a mouthpiece attached to a regulator. When you breathe in, the gas is released and you can breathe out through the mouthpiece as well. It's very short acting. It works within about 20 seconds of breathing on it, and it stops working and passes out of your body within another 20 seconds. So it's in and out really fast. So if you don't like it, you just stop and it's gone. It has no effect on your baby in your womb. Sometimes it makes people feel a bit sick, but it's worth persevering with if it does make you feel sick, because that feeling normally passes fairly quickly, and most people find it very useful in labour. It also helps you regulate your breathing, because you have to breathe fairly steadily and slowly and deeply on the mouthpiece, and that can be really calming. The equipment, when it's being used, sounds a bit like Darth Vader, and if it doesn't sound like Darth Vader, then you're not breathing hard enough on it, so try and pull a little bit harder on the mouthpiece. Remember to eat and drink during labour, especially drink. You can be in labour for a very long time and it's really important to stay hydrated, and snacks are really important too, so that you keep your energy levels up. Your appetite may go down, so light things like biscuits or rice cakes or fruit slices, these can all be palatable to you when you're in labour. As to drinks, water is fine, but energy drinks can be helpful as they contain calories and energy. This picture shows a few of the positions that you could try in labour. Have a look through it and see what you think of them, and see which ones you think you could maintain for any length of time. I think what it most usefully shows is the importance of changing position and trying different things.
Hi, my name's Sophie Hasty and I'm the Parent Education Midwife, and I thought I'd make this little film to show you roughly how a baby comes out in normal birth. So this is a model of a human pelvis, a woman's pelvis, and it's made up of lots of bones, and in pregnancy a hormone called relaxin makes the ligaments and muscles that hold the bones together a little bit loose so that it can move to help your baby out. And it sits in the body. Oh, I haven't introduced Chris. This is Chris. He's my able assistant, and he's just going to pretend to be a woman in labour, which is a completely normal thing to do for a man. He's going to hold the pelvis between his knees, and it sort of sits in that kind of position in the body. It's slightly tilted forward, and you can see that there's a bit of a bend in there that the baby has to come round. And here we have our baby, and this baby is in a nice head down position in the pelvis, and Chris has gone through the first stage of labour, so his cervix is fully dilated, and he's feeling urges to push now, and feeling really quite strong urges to push, and he's pushing really well. So you can push, Chris. Maybe not. And he's been pushing for about an hour, and the baby's head's come down really well, and we can just about see the baby's head now when he pushes really hard. So we can see a little bit of the head, and then between the pushes it goes back a bit, and with the next push we can see a little bit more, and then it goes back a little bit less. So he has to, it's kind of a rocking motion, getting the baby to come round through the pelvis. And then it will get to a point where we can see about that much of the baby's head, and it doesn't go back in between the contractions. And that's what we call crowning. And at that point, the skin around the vagina and the perineum, which is the piece of skin between the vagina and the anus, is really stretched. It really stings. You really need to try and push through that stinging. And then slowly, the midwife will encourage you to stop pushing and just to breathe. Your baby's head should just slowly come out. And that it hopefully only through 1, maybe 2 contractions, but it is very stingy. Just try and breathe through that. And there we have the baby's head out. And the baby's head will normally turn to one side or the other. And the midwife will put her hands around the baby's head, and then with your next contraction, she will encourage you to do a huge push, and she will just gently guide your baby's head and bring your baby round. Oh, and up, and then pass your baby straight to you. Well done, Chris. Congratulations. You did ever so well. Now, obviously, if you're sitting in this sort of position, this is how your baby will be born. But if you were on all fours, which is a completely fine position to give birth in, it would be the other way round. And then the midwife would pass the baby through your legs straight to come to you. You'd pick it up off the surface that you were on. So then you're left, baby's born, placenta's still inside, and cord is still attached to baby. The midwife would wait until the cord has stopped pulsating, and then she would clamp and cut the cord, or you could do that, or your partner could do it. So we'll just separate the cord from the baby, and then you're left with the cord hanging between your legs. Most people will have an injection at this point to help their uterus expel the placenta. After we'd given you the injection, after about 5 minutes, the midwife would put her hand on your tummy, check your uterus was nice and hard, then press above your pubic bone like that and pull gently on your cord so that the placenta came out like that. And that's the end of the 3rd stage of labour. I'll give you a little bit more detail about labour and birth through the next couple of slides. Thank you very much.
We encourage mums to have skin-to-skin contact with their babies as soon as possible after birth. Usually this is straight away. Skin-to-skin is when your baby is placed naked onto your bare chest. This helps babies feel safe and secure. Your baby has been listening to your heartbeat in your womb for the last 9 months, so when they are on their chest, they can hear it there too, and it soothes them. It also helps regulate their heart rate, temperature and breathing, and facilitates the bonding process between you and your baby. When you have skin-to-skin contact with your baby, you will both have a rush of oxytocin, the love hormone I discussed earlier. This bathes your baby's brain, which helps it to develop and grow. If you have a caesarean birth, you can still have skin-to-skin in the operating theatre or in the recovery room. If you feel unwell or unable to have skin-to-skin with your baby, then your partner can do it, and your partner can have skin-to-skin with your baby. Babies will often find their own way to the breast if they have uninterrupted skin-to-skin contact. But skin-to-skin is not just for breastfed babies. It is important for bottle-fed babies too. After your baby is born, the placenta still needs to come out. This placenta is the afterbirth, and it's what keeps your baby alive in your womb. Many women will have an injection just after the cord has been clamped and cut, and this makes your uterus contract really hard, and it shears the placenta off the wall of the uterus, and then it can be born very quickly. Left to its own devices, the uterus will shear the placenta off its wall, but it takes much longer. It takes up to an hour, and it's thought that there may be more bleeding if you don't have the injection. If your labour and birth has been straightforward and you've had no drugs or medication to speed your contractions up, and your labour hasn't been too long, it's probably not unreasonable not to have the injection, but speak to the midwife looking after you and she will advise. Many women will need some stitches in their perineum after they give birth to their baby. The perineum is the piece of skin between the back of the vagina and your anus. It has to stretch a great deal to allow your baby out, and trauma to it is very common. Sometimes if you need some help for your baby to be born, then the midwife or the doctor may cut your perineum, and this is called an episiotomy. This would always need to be stitched after the birth of your baby. The person doing the stitching would always put some local anaesthetic into your perineum first. There is some evidence that if you massage your perineum from 34 weeks of your pregnancy, you can reduce the chances of you needing stitches after you give birth to your baby. You can do it yourself, or if you feel comfortable with this, your partner can do it for you. Massaging during or after a bath may be helpful, as the warmth and water will dilate the blood vessels and make the perineum softer. It is easier and more comfortable if you use an unscented oil such as sunflower oil or grapeseed oil, or a lubricant such as KY jelly. Make yourself comfortable in a place where you feel warm and safe and are not going to be interrupted. Some people find it helpful to play relaxing music. Lying back, propped up on pillows with your legs drawn up, put your thumbs inside your vagina and gently pull your skin away from your body, at the same time pressing with your fingers through the outside of your perineum, so you massage your thumbs and your fingers towards each other. Try and do this a couple of times a week for about 5 minutes. We have produced a separate virtual presentation on perineal massage, which you may be interested in if you want more information about this. Your baby will be weighed shortly after he or she is born. I'm sure you'll be very excited to know what your baby weighs. You may want to wait before you contact all your friends and family to tell them your baby has been born until your baby's been weighed. It is very quick, and if it does need to interrupt skin-to-skin contact, it is better to do it very early rather than interrupt the process of skin-to-skin half an hour in. Vitamin K is an essential element in the body that helps blood to clot. Babies are not born with any vitamin K in their system, and they get it from milk. In the early days they don't have any at all, and we recommend that babies are given an injection of vitamin K shortly after birth to facilitate their blood clotting. The reason for this is that about 1 in 10,000 babies, if they don't have the injection, will get a condition called hemorrhagic disease of the newborn, which can cause very serious bleeding. Part 2. Complications and common medical interventions. In this part of the presentation, we'll have a look at some of the things that can happen in labour and interventions that midwives or doctors may carry out. Just because these are happening doesn't mean you can't move around. You may still be able to use a birthing ball or a birthing pool. And most of the natural process of labour will still apply. If you're not sure why any interventions are being carried out, always ask so that you can make an informed decision about whether or not you're happy for them to happen. If all is well with your pregnancy and your labour and birth, then the midwives will just listen to your baby's heartbeat with a Doppler, just like at clinic, every 15 minutes after a contraction. If there are any concerns about your baby's heartbeat, you may be asked to go onto a monitor called a cardiotocograph or CTG so that we can keep a closer eye on your baby's heartbeat. We put 2 elastic straps around your tummy, one to pick up the baby's heartbeat and one to monitor the contractions, and it gives us a paper printout of your baby's heartbeat in relationship with the contractions, and so we can see how your baby is coping with the contractions. You will normally go into natural labour between 37 and 42 weeks of your pregnancy. Once you've reached your due date, we know that the placenta stops working quite so well, and by 42 weeks the function is considerably less good, and that puts your baby at risk because your placenta is what keeps your baby alive. Once you reach your due date, your midwife may offer you a stretch and sweep. This is a procedure whereby the midwife would do a vaginal examination, which means putting 2 fingers inside your vagina, trying to get 1 finger inside your cervix and sort of stir it with the aim of sweeping your membranes off the inside of your cervix. This can be a bit uncomfortable, but if you find it too painful, just ask the midwife to stop. So once you reach your due date, we can do this, and then maybe do another one a few days later. The evidence is that if your cervix is favourable, most women will go in, about 50% of women will go into labour within a week of having a stretch and sweep. Once you reach 10 to 12 days after your due date, or if there were any concerns about your pregnancy, maybe your blood pressure was high, or there were concerns about your baby's growth, or you had diabetes, then you would be recommended to have a formal medical induction of labour, and that would take place in the hospital, starting off on Swan Ward and then proceeding to Labour Ward. When you arrive at the hospital, the midwife would examine you. She would feel your tummy to check your baby's position, check your baby's heartbeat, and probably do a monitoring of your baby's heartbeat. Then she would do a vaginal examination, just like a stretch and sweep, but she would put a pessary or something like a tampon impregnated with drugs into your vagina, and that would stay in place for 24 hours. Over the space of a couple of days, you can have up to 3 of these pessaries, and each one lasts 24 hours. You would be checked over at least once a day, and you would have to stay in hospital. If it became possible, the midwife would break your waters, and that may start your labour off on its own. If it didn't, it may be recommended that you have a drip to make your uterus contract more. That's a drip of a drug called oxytocin, which is a synthesised version of the hormone oxytocin, which makes your uterus contract naturally. Sometimes the midwives can assess how you are progressing in your labour just by looking at you and watching your demeanour, how your contractions are, how you're behaving during your contractions, and other visual signs. But this is not always possible, and sometimes the midwives need to do vaginal examinations to check that your cervix is dilating. Once we have established that you are in labour, and that's usually when your cervix is 3 to 4 centimetres dilated with good, strong, regular contractions, then we would recommend that unless you are obviously about to give birth, that we do further vaginal examinations around every 4 hours. This is to check that your cervix is continuing to dilate. We anticipate about 1 centimetre every 1 to 2 hours, but that's very variable. If the dilation of your cervix stays the same at repeated vaginal examinations, we may recommend intervention to encourage your labour to progress a little more quickly. The first of these interventions is to break your waters, and that is done during a vaginal examination using a plastic stick with a very gentle hook on the end. The midwife will run the stick along her fingers and feel for your waters and gently pop them. The hook will never come anywhere near your skin or your baby's head. Usually after breaking your waters, the midwives would wait for some time, probably an hour or 2, and then reassess your cervix to see if it had dilated any more. If it stayed the same, they would discuss your case with one of the obstetric doctors, and they may well recommend that they start a drip to make your contractions stronger and more frequent. While you are on this drip, you would always be on a monitor to check that your baby's heart rate was coping okay with the contractions, because sometimes the contractions can stress babies. You can be given injections of opiate drugs in labour as painkillers. Most commonly this is pethidine or morphine. They are given by injection into your thigh or into your buttock. They can make you feel sleepy and drowsy and help you sleep and rest between contractions, which makes them very useful in very early labour or if you have a long latent phase of labour. They do pass across the placenta, so it's better to have them early in labour rather than later, because if they're given late in labour, the baby can be born sleepy and then reluctant to feed. An epidural is a very sophisticated form of pain relief, which is often used in labour. It takes away a lot of sensation from the top of your bump down, so you cannot walk around once it's been set up. But it also takes away most of the pain. It is always set up by an anaesthetist who will ask you to sit on the edge of the bed and try to arch your back like an angry cat. They will put some local anaesthetic into your back, then put a needle into a very specific space between two vertebrae. When they are sure that this is in the right place, they will thread a plastic tube through the needle and then take the needle out. The tube is taped in place and nothing metal stays in your back. Drugs are put down the tube, which makes you numb below the level of the tube. It stays in place until your baby is born and is attached to a machine so that drugs are trickle-fed constantly into it. An epidural is a significant medical intervention, and if your labour is going well and there are no complications, it is worth trying to avoid having one. But if you are having a long, slow labour and are perhaps having a drip to make your contractions stronger or other complications, it is probably a good idea to have one. There can sometimes be problems with an epidural, such as a patchy block. This is when there is an area of the body which is not numb. The midwife will ask you to change position, as gravity will often help the drugs get to the painful area, and maybe top up the epidural with extra drugs. If that doesn't work, she will ask the anaesthetist to come back and adjust the epidural. It can also drop your blood pressure, which can stress your baby, so you will have a drip in the back of your hand so the midwife can give you fluids to counteract this. But you would also need to be on a monitor to keep an eye on your baby's heartbeat and check your baby isn't becoming distressed. Because you can't move around, you can't get up to use the toilet, so you would need to have a tube into your bladder, which is called a catheter, and that's attached to a bag. Probably the worst complication is about 1% of women will get a nasty headache from an epidural. And if this happens, the anaesthetist would carry out a procedure similar to having another epidural to correct it. Sometimes the doctors will make the decision that your baby needs to be born more quickly than you can give birth naturally. This is usually for one of two reasons. The first is that your baby's heartbeat is showing signs that the baby is distressed and not coping with your labour. The second is that you are not making progress, so you have been in labour for a very long time and you are becoming exhausted, or you will become exhausted and your baby will probably become distressed if they don't act. If you are fully dilated, they would usually do a forceps or a ventouse birth. Ventouse is when they put a suction cup on top of baby's head and the doctor would pull on the handle of the suction cup while you push. Forceps are instruments that go around the baby's head and again, while you push, the doctor pulls on the handles of the forceps. Most commonly, the doctor would need to cut your perineum to do this procedure, and that is called an episiotomy. That would always be stitched after your baby is born. If the doctor is absolutely certain that they can deliver your baby safely in this way, they may do the procedure in the birthing room where you have been throughout your labour. If they are not 100% sure, then they will take you to theatre and prepare you for a caesarean section, so they can proceed to caesarean section if the forceps or ventouse don't work. They would make sure you had adequate pain relief before they did any of this. So if you had an epidural, they would top it up so it was more effective. And if you didn't have an epidural, they would do a spinal anaesthetic, which would act more quickly than an epidural, and it often gives you what we call a denser block, so you are more numb. Caesarean sections can be classified into two types: a planned caesarean, or also known as elective, or an emergency. A planned caesarean section is usually done for a reason such as your baby being breech, which means bottom down, or because you've had a caesarean in the past. On the agreed day, you would go to the hospital. First of all, you would go to Swan Ward, and then when the theatre staff were ready for you, you'd walk round to theatre. The first person you would meet would be the anaesthetist, who would put a drip in the back of your hand and then put a spinal anaesthetic into your back while you were sitting on the edge of the bed. Once the spinal was in place, you would be asked to lie down, and the midwife would put a tube into your bladder, which is called a catheter, and this is to keep your bladder empty. Once the staff were sure you were numb, the operation would start, and your baby would normally be born about 10 minutes later, but the whole operation takes about an hour. Usually once your baby is born, you can have skin to skin straight away, and your baby can stay with you all the time. You would go round to the recovery room when the operation was complete and stay there for about half an hour before going back to the postnatal ward, that's Swan Ward. An emergency caesarean section is a section that is done during labour because there are either concerns about your baby or you're not making progress. That means your cervix is not dilating. You would be taken from the room where you had been in labour to the operating theatre. If you have an epidural in place, that would be topped up until the staff were confident that you were sufficiently numb for them to proceed. If it's an emergency, it is done very quickly, and this can be really frightening. It's still really important that you understand why the decision has been made and that you agree to it. You will be asked to sign a consent form, even in an emergency. If you have any questions, please ask. It is essential that you understand why this decision is being made, so you are making an informed consent. No one can do anything until you agree. Whoever your birth partner is, the baby's father, your partner, a close friend, or a relative, there's quite a few practical things they can do to help you. The most important thing your birth partner can do is just be there. Talk to them beforehand about what type of birth you'd like and what you hope for and what your fears are and what support you want from them. You might want to write a birth plan together. There's no way of knowing what your labour is going to be like or how each of you will cope. I like to think of labour being a bit like going on a picnic in August in England. You hope for a beautiful day in a lovely meadow with lots of flowers, but there might be a thunderstorm and you don't know which way it's going to go. So try not to be too fixed about how you hope your labour's going to be. Whatever type of birth you're planning or hoping for, your partner can keep you company and help pass the time. Hold your hand, wipe your face, massage your back, and comfort you. Just being there is what really matters. You may find that whatever plans you've made, you change your mind, and that's really important to acknowledge. And also for your partner to accept that if you've said adamantly you don't want an epidural, and then you ask for an epidural, that's okay, and you're allowed to change your mind and not stick too rigidly to the birth plan. Your partner can also be an advocate for you, so can talk to the midwives and the doctors on your behalf and say what you wanted and what your hopes and your fears are if you don't feel like talking. It's important your partner thinks about how they can help themselves as well and look after themselves. Remember, your partner's going to need to go to the toilet at times, might need to step out of the room at times or go for a walk, and that's okay. It can be pretty stressful watching somebody you love going through labour, so don't give them a hard time if they need some time out. Maybe spend some time on your own and your partner on their own, thinking about what support you want and need and what support you can give each other. Write those down and then sit down together and compare notes. I bet you find there's a lot of similarities. You may decide that you want to write a birth plan. You can write it as a Word document if you like, or you can find a template online. This one in the picture is from the NHS website, but there are lots of other templates online that you can find, and some of them use pictures rather than words, and those are really easy for the staff to read. Remember my picnic analogy from a moment ago. You don't know how your birth is going to be, so go with the flow and take it as it comes. That would be my best advice to you. In a moment, you will hear a lovely relaxation session recorded for us by Marie Ashford. Relaxation is a very useful tool to help with anxiety, worries, and just difficult things happening in your life. It's also very useful in pregnancy, going through labour and birth, and when you're living with a newborn baby. And of course, in these anxious times dealing with the COVID-19 pandemic, doing a relaxation session every day will really help any worries you have about that. It lasts about 8 minutes. I'd really encourage you to listen to it all the way through and follow the instructions.
When you're ready, let your eyes gently close and start to focus on your breathing. Breathing easily and comfortably. Noticing the air coming in through your nose and out through your nose or mouth. Just letting your breath come and go as it naturally does. Breathing in and breathing out without trying to change anything. Maybe noticing where in your body you feel your breath the most. Perhaps in your nose or your throat, or your chest or your belly. Just keeping as much of your focus as you can on your breath. And if your mind starts to wander, as it will, acknowledge those thoughts and then gently bring your focus back to your breathing. Allowing any sounds around you to help you feel safe. Allowing those sounds to help you relax a little more. Now take a couple of deep breaths, slowly filling your lungs with fresh air, and as you slowly exhale, you relax more and more. With each breath, relaxing more and more. Imagine you can breathe in peace and calm. Imagine you breathe out tension and worries. Breathing in peace and calm. Breathing out tension. Just just letting your breath come and go naturally. Maybe noticing the way your abdomen gently rises as you take a breath in and deflates with each out breath. Abdomen gently rising as you take a breath in, and as you exhale, imagine the breath drifting down through your body, down through your legs and out through your feet. As you exhale, you direct your breath all the way down through your body, down through your legs and out through your feet. With each out breath, relaxing more into the chair, allowing your body to feel a little heavier. And now, maybe noticing the slight pauses between an in-breath and the following out-breath. And between an out-breath and the following in-breath. Just being aware of those slight pauses. Or if you prefer, focus on a place in your body where you find the sensations of breath most vivid and distinct. Allow each breath to relax you more and more. As you continue to breathe in peace and calm, and to breathe out tension from your body. Softening the muscles in your face, relaxing your shoulders. Allow your shoulders to drift down into the rest of your body. And if your mind begins to wander, acknowledging those thoughts and gently bringing your focus back to your breathing. Breathing easily and comfortably. Now, in a moment, it's going to be time to finish this relaxation. So start to focus more on your in-breath and imagine drawing energy into your body. Starting to become more aware of the sounds around you. Moving your legs and feet. Moving arms and hands. And when you're ready, opening your eyes to feel awake and refreshed.
I hope you have found this presentation useful. If you have any questions at all, please contact your midwife or the maternity unit at Warwick. We hope to recommence the Full Path to Parenthood programme as soon as possible, and I do hope you understand why we felt that we've had to cancel it for the time being. Good luck!